Discussion about cardiomyopathies, which is a disease of the myocardium itself. You have dilated cardiomyopathies, which are by far the most common, and 30% of them have an inherited component to them, which basically means that you have a risk of developing cardiomyopathy. You might not necessarily develop it, but if you go on to have an insult such as an ischemic event, or toxins, or medications such as doxorubicin for treating cancers and oncology patients, then you're at risk of developing a dilated cardiomyopathy. Alcohol and chronic alcohol misuse is by far the most common cause for it. Second to hypertension and ischemic heart disease will also cause a dilated cardiomyopathy. So findings you'll find with someone with dilated cardiomyopathy will be an S3 heart sound with rapid ventricular emptying, and then you'll have dilated ventricles that will be seen on the echo. And then on an X-ray you might also find cardiomegaly with a globulous shaped or round shaped heart, which can be seen. So treatment with ACE inhibitors obviously treat the underlying cause such as alcohol disease or thiamine B1 deficiency, but ACE inhibitors have been shown to reduce the amount of cardiac remodeling. This is a big buzzword for selling ACE inhibitors, that they do reduce cardiac remodeling, whereas most of the other cardiac medications have not been demonstrated to do so. So this remodeling is a maladaptive response, and unfortunately has a very poor prognosis once you have a dilated cardiomyopathy with congestive heart failure. Second would be hypertrophic cardiomyopathy, and this is obviously a different type of cardiomyopathy. It's an autosomal dominant inherited in 50% of the cases, and it's to do with a sarcomere abnormality, which is inherited, and this is a common cause for death in young, sporty people. And basically, you develop abnormalities of the cardiac myocyte, which causes basically tangled, disorientated, hypertrophic myocardial fibers, and these are mainly in the ventricle septum, which is close to the mitral valve, and that causes outflow obstruction. So when you have something like left ventricular hypertrophy secondary to hypertension or aortic stenosis, this will cause a concentric hypertrophy, meaning the whole wall will be thickened, and that's why you don't develop outflow obstruction, because it's a smooth growth of the whole of the left ventricle. Whereas in primary disease of the myocardium, such as HOCM, the intraventricular septum is the main source of hypertrophy, and that will eventually cause an outflow obstruction through its effects on the mitral valve mainly. So the treatment is angina, to treat angina. These patients, unfortunately, due to having such thickened myocardium, have an increased oxygen demand, and they also have an inefficient ventricle, which requires more oxygen to do the same amount of work as an efficient one. And they also unfortunately get shortness of breath and arrhythmias. So beta blockers and calcium channel blockers are the mainstay of treatment, but you don't want to off-preload too much, as this is the thing that's giving them cardiac drive when you go back to the Starling curve. So you don't want to give too much of a diuretic or something similar, which will reduce his patient's preload. Then you have restrictive cardiomyopathies, which can be either primary or secondary. Primary would be Loeffler syndrome or endocardial fibroblastosis, which is exceptionally rare. Loeffler syndrome is eosinophil infiltration in the myocardium. And endocardial fibroblastosis is in 2-year-old children, which causes a restricted cardiomyopathy. So as the name suggests, they have rigid walls which do not fill properly, and this reduces the amount of preload that the myocardium will receive, and also the end diastolic volume. And this will eventually lead to diastolic dysfunction. And we know that diastolic dysfunction is a dangerous thing to have, because this is when the coronary vessels fill. So when the heart is relaxed, the coronary vessels will be more patent, and also the blood will flow down from the aortic cusp and fill the coronary vessels this way. So if you have diastolic dysfunction, you have less time for this to happen, and you'll unfortunately develop myocardial ischemia. So the treatment for this would be treat the underlying cause, and then to continue with the cardiac prophylactic medications such as beta blockers and calcium channels, and trying to increase the amount of oxygen received by the heart in this case. And then finally, you get arrhythmogenic right ventricular cardiomyopathies. This is autosomal dominant, and again, a very common cause for sudden cardiac death in the young. And this is when the right ventricle will develop fibrofatty replacement of the myocytes. So myocytes are quite important in the fact that they've not been shown to divide or replicate. So once they die, you won't unfortunately get scarring. But in this case, you have fibrofatty replacement of myocytes, which is maladaptive, and this is pro-arrhythmogenic. So when you do an echo on this patient, you'll have a hypokinetic right ventricular wall, as these layers of fat obviously have no contractility to them. So hypokinetic right ventricle, and this is pro-arrhythmogenic, so they're at risk of ventricular arrhythmias such as VT and VF, and high risk of sudden cardiac death. And so you basically will screen patients, and you can do ECGs, and the most common thing you'll find is a right bundle branch block in the young. And these patients should go on to have ICDs, implantable cardiac defibrillators implanted. So if the patient was to go into VF, then hopefully this patient could be cardioverted out of it.